Dr. Benjamin is the Executive Director of the American Public Health Association and has been so for almost 20 years now. He's board certified in internal medicine and a fellow of the American College of Physicians. He is also a fellow emeritus of the American College of Emergency Physicians and an honorary fellow of the Royal Society for Public Health. So thank you, Dr. Benjamin, for joining us again today. So I'll maybe launch into the questions. And maybe the first question I'll ask Dr. Benjamin is, do you think economic analyses of the impact of the pandemic is going to be enough to ensure that governments don't do what you showed us in the slides, where funding for public health goes up at the time of a crisis and then rapidly deteriorates soon thereafter? Do you think, showing governments how much was lost with the lockdowns and with the various cycles, will that be enough to convince governments to not cut public health funding immediately post-pandemic?
I don't think it'll be enough. I do think we need to make sure those economic analyses are done. But I do think that like everything else in life, the way you get support is because people have a shared value for what you do. If you think about it, we have, in the United States at least, we have every member of Congress is a member of the fire caucus for firefighters. And, we've done a really great job of preventing fires in our country. And I remember once I was the health officer in DC and we were trying to close the fire station, which is a little bitty building right down the street from the US Capitol. And they refused to let us close it, even though the building was never used to respond to a fire at the Capitol. It wasn't in our plans to use that building because they supported firefighters and they had a value. They thought firefighters had a value. And I think the one thing we have not really done a good job of in public health is making sure people understand that the food is safe to eat, the water is safe to breathe, and the air is safe, the air is safe to breathe and the water is safe to drink, because things they do every day give them value. And we have failed to make the connection. And now that we have an anti-government movement, of course, around the world, people are revolting against government. So I think we've got to figure out how we bring value to what we do every day, so that when somebody wants to cut the budget of the public health agency, there's a huge uprising that we don't start, that we don't have to start.
So a follow-up question, this one from Lynn McIntyre, talking again about the huge economic impacts of the pandemic and asking specifically, how is the American Public Health Association weathered the downturn? And any other words of wisdom for other non-governmental organizations?
Thank you. So last year we actually did okay. We were able to, many of you know, those of you who have been to our meeting, know that it's 13,000 of your closest friends. It's a big meeting, lots of face-to-face. People go for both the science and the networking. And we went to an all virtual meeting, which, by the way, was very successful. We had about 8,100 people that participated. And from a financial perspective, we worked with our board to craft a budget. We had substantial reserves to be able to go in our reserves. Looks like, by the way, we will not need our reserves. We had put, quite frankly, $2 million aside in case we needed it. Having said that, looks like this year is going to hit us. Many people in public health are still not quite back at work, so our membership is kind of flattened. Many of our publications, the places where we sell our books, of a small book company, that revenue stream, although the journal has done okay, our books department really hasn't done as well as we would like. By the way, many of our customers are in India. So that explains that. So at least our revenue projections for this year are pretty flat. So while we didn't go into reserves last year, we may have to go into reserves this year to some degree. We didn't want to do layoffs. We felt that would be counterproductive. Because, once you do that, you don't build that capacity back. It takes a long time to do so. So the good news is we spent the 20, almost 18 years, I guess I've been here at APHA, building our reserves up so we'll be able to do that. And by the way, many of the other nonprofits have had the same problems. All of our affiliates were substantially impacted because the way they fund their organizations is through their annual meetings. And many of their annual meetings did not happen, or they happened virtually at a very, very low cost. And they're struggling right now.
Right. Now, a couple of related questions about communicating science-based messages to the public, and how do we earn public trust or earn back public trust? You've alluded to in a couple of your slides, you were showing this is a phenomenon that's been seen in the 1910s, 1920s, 1930s, so it's not unique to our current time and place. But how do we get back the public trust and teach the public that science evolves? Because there is a lot of skepticism when they hear, don't wear masks, wear masks, take masks off, don't take masks off. So how can we better do that in the future?
So let me first, by dividing that question. First of all, we should recognize that people still like us. They still trust us in general. We've lost some trust around particular issues, and but overall, the polls, at least in the United States, still show that doctors, nurses, scientists, and public health practitioners are well thought of. We're much well thought of, higher than politicians and lawyers. So to my lawyer friends, I'm sorry. Now, having said that, I think the way you maintain trust and rebuild trust is to be as transparent as you can. And, you know, trust doesn't come overnight. So to the extent that we've lost trust in some areas, we're going to have to spend time actually rebuilding that trust. You build trust by being there before people need you, before you need them, and being there when they need you. And that means talking to communities, being in communities, helping them solve their problems, being honest with them, telling people what you know, telling what you don't know. And I think a lot of our communication failed us because up front we didn't say, look, this is a fast-moving new disease that we've never seen before. And what we're going to show you is that we're going to show you how science is done in real time. And what I tell you today is what my best understanding is today. And what I tell you tomorrow may be different. And when we come back and tell people, yep, I've changed my mind because of this, explain it to them. And far too often we try to do it in a soundbite. So my best example is the mask issue. We didn't spend a lot of time telling people why not to wear masks initially. And then when we changed to wearing masks, we didn't tell them why to not change masks. By the way, we just screwed it up again. The CDC, I think, made the right decision. Some of you may know in the United States, they've now said if you're fully vaccinated, it's okay not to wear a mask both indoors and outdoors, except in certain situations. That required a primetime press conference with a full explanation about the change. And what's happening now is they're taking the flak. They've lost some trust. People are not listening to them. They're under political scrutiny. And they also broke the cardinal rule. You know, the president didn't find out about this decision until 9 o'clock in the morning, right before the decision was announced, even though his people knew about it. Never surprise your boss.
Right. So that leads into one of the questions in the question and answer box, where Fabiolo Aparicio Ting has asked if you had one or two key messages that we need to teach our future public health workforce, what would be them? I'm guessing one, you're saying be transparent in the messaging. Is there another key message?
Well, I think first of all, you know, this is hard work. And get some crew rest. You know, we burnt out a lot of health officers. We had people leave because they were threatened. We had people leave because they were tired, and they didn't pace themselves. And I think the first thing is do what you like, but you cannot save the world if you're too tired. And we had far too many of our health officials who just worked their tails off. That's the first thing. I think the second thing is it ain't over. And we need to now plan for what the world looks like in a disease which I believe will be endemic. In other words, I believe this disease over the next few years at least, unless it mysteriously goes away like SARS-1 did, which I don't think it's going to do, well, we have many outbreaks, just like measles outbreaks, just like pertussis outbreaks, that we're going to have to plan in the community for an outbreak of 10 people or 20 people, and then make sure we have the capacity to do, testing, contact tracing, isolation, quarantine, and build the political support for that. Because many of those people are going to need to be vaccinated for the first time, because, like measles, it'll be in communities that never got vaccinated in the first place. It'll be people who were inadequately vaccinated, and there'll be people who were vaccinated in that population. And then we have to be concerned about the fact that people will say the vaccine didn't work, but it did. And we need to prepare for that future. And I can tell you, I don't believe that we've done so yet.
So that point about vaccines leads into the question about what's your personal view on vaccine passports, or the APHA viewpoint?
I can give you my viewpoint. We don't have a policy on it, but I'm opposed to vaccine passports with the following caveat. I think the first problem is that we have a vaccine that we can't mandate yet, because at least in all situations in the US, it's under emergency use authorization. And I don't believe you should mandate that for anyone. I am absolutely perfectly fine with, once it's fully authorized, for schools to require it, and camps to require it, and the places where we've done so in the past. I think it's going to be very problematic for businesses to require it, with a few exceptions. The military may decide to do it, for example. There may be some security places. The people who run our nuclear power plants, because they have to be isolated. If you're on a nuclear sub, yeah, you probably got to be vaccinated. So there are certain occupations where you need to be vaccinated for sure. Working in a lab, right? Healthcare workers, I think you should be vaccinated. Now, but for me to have to show it to go in a restaurant or a store, or to go into a sports stadium, I think that's an overreach and a slippery slope. Now, if you tell me that if I show you, oh, by the way, I can't validate that your vaccine is real, your card is real. There's so many fraudulent ones out there now that it makes it almost useless. Now, if you can prove to me, if you can go through all the process like a passport, and validate that it's real, and validate it as a medical document, and then tell me that I can use that in lieu of a test to go on vacation. Just like with my yellow fever vaccination, I'm okay showing that to the authorities in order to enter another country. But I think we have to be very careful that it can be misused, particularly in the United States, where I think employers will use it to not hire people, to fire people, where insurance companies will use it to raise your rates, where people will use it to stigmatize and attack you. I think it'd be very, very careful about it.
So that leads into the question, if, let's say we have a COVID 2030, do you think governments will be faster next time, or will it be the same questions about closing borders, locking down, keeping non-essential workers at home? Or are we just going to read the same pattern?
I think the challenge is, I think they'll be less likely to shut things down. I think the hesitancy of governors and elected officials to shut down the economy because of the economic turmoil, they may be slow to do it when they probably need to be quicker to do it. As you know, the last time we actually really did this with any gusto was 1918, 1919. Some of it did happen during H1N1 around the world, but not a lot. And then SARS-1 went away too fast to really have to do it, at least on a global scale. I think they'll be a lot slow to do it. And I think that one of the things that we failed to do from all these preparedness exercises we had is we really haven't really figured out how to bring public health effectively into the emergency response activities with our governors and mayors. We had governors and mayors in the United States making public health decisions as political decisions that they never should have been making. And using authorities, by the way, that I think legally they didn't have. You know, a lot of the public health authorities that I had as a health official were legally mine and not the governors, not the mayors. And in some cases, they usurped those authorities as though they were. And I suspect if somebody challenged them in court, they very well may have lost.
Yeah, no, and the same debate has gone on in Canada, particularly in Alberta, around there. A couple of related questions. So I'll start with Dr. Cawthorpe's question about what do you see as the role of the American Public Health Association on understanding and promoting the role of complex morbidity and in the kind of post-pandemic world?
Yeah, I think we've got to think. I think we've got to think a lot more thoughtfully as a health field about how we manage more than one disease outbreak at the same time. I think in the U.S., you know, we again, there's a couple other things that happened that I didn't, you know, put in my talk. So as you may know, we had a hurricane that hit Puerto Rico, and then they had an earthquake. And what folks may not know is that a fair number of pharmaceuticals are produced only in Puerto Rico, and they are one of the sources of our infusion bags. So we had problems getting infusion bags just to give people, you know, saline and medications, et cetera. Some of those pharmaceuticals, the Food and Drug Administration had to go to Puerto Rico to try to shore up those plants. We also had a climate change related event in the US in Texas. And we had all the power went out in Texas for several days, you may remember. That was a major public health event during the pandemic. So it closed down vaccination sites not only in Texas, but in many parts of the country because of the transportation of commerce and people being able to get the vaccines around. So we've got to figure out in the United States, and I'm sure you do too, is how do you do more than one thing at one time? Because we're so codependent. Our supply lines right now, you know, even though people are talking about the issue around the rights of the for the vaccines, the real problem, of course, as many of you know, is the raw materials and the ability to actually make the vaccine. And we have a just in time supply system, and we have our raw materials are monopolized by small numbers of countries. And so if those countries ever got mad at us, not only could they call in the US debt, which is always a big issue for us because they own our paper, but they also could limit us raw materials. The Japanese bombed Pearl Harbor because of our embargo on raw materials. So wars start over this stuff. And we have to think more strategically about access to stuff and how to do that without nationalizing things to a degree that we are not good global partners.
Right. A question here from Dr. Karen Lee. So I'll just read this out and let you respond to it. And how are we planning to ensure increased concerted efforts in chronic disease prevention and management in public health as a measure to both increase the relevance and profile of public health between pandemics, as well as to prepare for the next pandemic and even to improve our annual response to seasonal epidemics like influenza?
Yeah, we've got to make sure people understand that the number of people who die each year from tobacco-related diseases, the number of people who die from cardiovascular disease and cancer, et cetera, are major problems in our country, and we've kind of normalized them as just acceptable outcomes, and we've not really been able to, at least not yet, argue the preventive aspects, and it's going to take some work. But now look, everybody knows the word public health. They don't necessarily know who we really are. Everybody has a different definition. A lot of people still think it's the doctors and nurses who are running the ICUs and the ERs are the public health practitioners. And so I think we're going to need to make sure people really understand who the preventionists are in the country, and figure out how to focus more on the upstream solutions. But we need to do that with some deliberation. Now, we have a coalition at APHA across sectors that we've put together that right now is focused on COVID, but the agenda is for this coalition to pivot next couple months to trying to sustain interest in public health, build an organized public health system that we need for the next century, well, at least for the next 20, 30 years at least, and to keep people's interest in investing in public health. We think it's going to take about $7 billion more a year in investment. And our argument is spend the $7 billion a year to avoid the $2 trillion in other costs that you certainly had. And by the way, we've actually spent in the U.S. We've spent somewhere around $7 or $8 trillion is what we're planning on spending, just to try to shore this thing up.
Right. Yeah. No, and that kind of feeds into Dr. Wolf's question about public health being intersectoral. Sorry. And so really about how to make decisions about reallocating funding for public health versus some other priorities within the healthcare system.
Yeah, someone asked earlier about the issue of the economic analysis. I think we need to do a better job of the economic analysis. So to try to capture what we call, the wrong pocket issue, where you do something on the healthcare side, the savings is on the non-healthcare sector. And then they only count the healthcare costs, they don't count the little bit of healthcare savings, and they don't count all the enormous costs that occur in other sectors. And we need to do a better job of catching that. The other thing we need to do is do a better job in the economic analysis and the number of years we capture it, so that we look at things like years of productive life loss, years of disability life years, and build those into the economic models so that people can say, yeah, we prevented cancer, but the savings is 20 years away, and that's okay. This person worked the extra few years of life, and we build that economic productivity into our economic models to make a big difference. But it's going to take us getting these historical, very conservative economists to recognize that as real savings.
Right. Yeah, and certainly one of the issues we have, when you mentioned the data problem earlier, within Canada, we can get access to the health claims data. So we know how much things cost for health, but we can't access justice data or social services data. So loss of time from work, et cetera, would be a big part of that question that we need to get to. So a short question here from Dr. Senthil, who's asking what percentage of people should be vaccinated to reach herd immunity, presumably for COVID-19?
The politically correct answer is, let's not pick a particular number, but let's just try to get as many people vaccinated as we possibly can to reduce the spread. But the scientific answer is somewhere between, probably 70, 80% of a combination of people who've been vaccinated and have had the disease. We keep talking about the vaccination number only, and we keep forgetting the other numbers. In the United States, again, we've had about 157, we have 331 million Americans. We've vaccinated with at least one shot 157 million people, and we've had about 33 million people that have had the disease. And then almost 600,000 deaths. If you put all that together, realizing there's some overlap between the vaccinated folks and the people with disease, we're pretty near 60%, maybe 65% of our population has been, vaccinated or had the disease. And by the way, there are some estimates that the number of cases is twice the amount that we have, because there are many people had asymptomatic disease that we really haven't captured, and our surveillance systems didn't pick up a lot of people.
Right. Yeah, yeah, and certainly.
So we may be close to that, and we're seeing a phenomenal reduction in cases, hospitalizations, and deaths. As you know, is exponential going up, but it's also exponential coming down. And so I suspect that we may very well be nearing functional herd immunity, even though the epidemiologists and the people that really know what they're talking about are going to probably tell us we're not there yet.
Right. Okay. No. And another question here, this one from Dr. Hagan, asking about chronic disease represents 80% of the disease burden, yet there's the perception that most of the prevention funds, even before COVID, are going to infectious disease prevention. So how do we change that? And you talked about this a little bit earlier, changing that focus to recognize the chronic diseases and the cancers and the cardiovascular disease where the benefits are more remote than preventing an infectious disease.
Yeah, we've got to partner more effectively with our chronic disease colleagues. They have more powerful lobbies than we do. I mean, but it truly isn't as much on the prevention side as it needs to be. So, the National Institute of Health, which has billions and billions and billions of dollars, and recently went through an exercise where they doubled the NIH budget. The Center for Disease Control and Prevention budget is a drop in the budget of a bucket of the federal budget. And yet a lot of the money that is spent at the National Institute of Health, while it goes to heart disease and cancer and things like that, it far too much of it, well, a lot of it goes to treatment, and probably not enough of it goes to prevention. Now, they would argue that a lot of what they're doing is clinical prevention. And I would argue that it may be prevention. I'm doing a study about whether or not aspirin prevents heart attacks. Is certainly a prevention study, but a study that would result in preventing people from getting atherosclerotic heart disease because of behavior change, to me, would be a lot more effective than taking an aspirin pill.
Right.
Yeah. And that's the studies we need to be funding.
Right. And getting back to the concept of primordial prevention way back.
Oh, absolutely. Absolutely.
So the last question we'll address today is a question from one of our student members asking about what can students in public health do to make an impact on how public health is perceived by the public, politicians, how it is funded. What would you say to the next generation, many of whom are participants on this webinar?
Yeah, well, I'm excited about students because there's a lot of student interest in public health, and I would encourage you to, first of all, do your studies and become very good at and knowledgeable of what you do. Second thing is get involved with your public health association. We can do a lot more collectively than we can individually. But as an individual, what you certainly can do is get to know your elected officials. Get to know them before they need you, before you need them. Because what will happen is once they know you're there, they know you're interested in public health, they and their staff will call you when they need something, when they need advice and guidance, and you become a trusted partner for them. I've gotten to know one of my city councilwomen here, and she'll call me all the time when she needs something, and I serve as a resource for her. And I don't need her to do anything for me right now, but if I have a public health issue, I know how to get a hold of her because I've built that relationship. So I encourage you to do that.
That's great and inspiring words for our youngest generation and the older generation like myself. So I'd like to again thank Dr. Benjamin for his contributions this morning, the excellent keynote and his ability to answer questions keep him on his toes with the question and answer period this afternoon in Washington, this morning in Alberta. So thank you, Dr. Benjamin.